Okay, so trying something a little bit different, going to go through this document and review for the CMPP exam. So we are just going to dive right into it. So I'm going to start with GI. If we have time later, we'll go through the pulm stuff. All right, so starting with the esophagus, I think the big part here is that it's kind of the same cell type as your skin, stratified squamous epithelium, but it's non-keratinized, so it's not as protected. That's why issues like GERD with acid are going to upset it so much. All right. It curves a bunch of times. Definitely know the lower esophageal sphincter is closed at rest. This could be a question. So the narrowest part of the esophagus is at the upper esophageal sphincter. It's located around C6, and it's controlled by the vagus nerve. So really anything with digestion, is going to be parasympathetic from what I understand. So that's where the vagus nerve will come in there. We have the lowest portion in terms of like blood supply drains into the portal system via the left gastric vein. So that is going to be important for like esophageal varices, secondary to like portal hypertension, things like that. All right, there's 3 phases of swallowing. You have the voluntary phase, oral. That's you actually chewing your food into a bolus. There's the transfer, which is kind of like a propulsion thing, which we'll talk about later with dysphagia. But that's where your tongue is actually moving the bolus into the pharynx, and that initiates the swallow response. And then we go into the esophageal phase, which is where, this swallow response, swallow mechanism is going to cause the contractions. And then more contractions will happen with the actual distension of the food bolus going down your esophagus. All right, moving into the stomach here. So the cardia is going to be that big entry point with the Z line. Remember, that's where squamous cells meet. The squamous cells of the esophagus are now going to become columnar cells of the stomach. And we'll talk about that more with Barrett's esophagus. The lower esophageal sphincter is actually part of the cardia. So it's that entryway into the stomach. Definitely have to know the cells here. So the chief cells are in the fundus and they release pepsinogen. So just think of a bunch of chiefs drinking some Pepsi. All right, that's going to combine with HCl to make pepsin, which is going to break down proteins. The antrum and gastrin, that's a huge one. So gastrin, which is released by the G cells, that is going to promote parietal, chief, and ECL cells to create all of this acid. So, when we eat, gastrin kicks in, and then all the acid starts coming to then break down the food. So that's really important. Parietal cells are releasing just straight H+, which is just protons. So that's just acid. And then D cells, this is important here. So somatostatin, this is going to slow down. This is going to end the process. So I believe when food is going through the pylorus and is now in the duodenum, D cells kick in, somatostatin comes in and stops all of this. It inhibits gastrin. It stops all of, it even says here, inhibits G cell and ECL and parietal cells. So it's going to stop all of this acid production. Yeah, pretty much everything I just said there. So somatostatin, sympathetic nervous system. So remember, it's going to be that's their fight and flight. It's the opposite of rest and digest because we're done digesting. So somatic or the sympathetic nervous system is going to come in there. There is that, remember, the endothelial surface of the stomach has that mucus bicarb phospholipid layer. It's like a protective gel. And then the columnar cells are actually kind of underneath that. So we get some mucin there to protect the cell wall or the stomach wall from damage. Here's a video I did not watch, but maybe should. So we already kind of talked about gastrin. So this, again, is big. It acts on the parietal cells, it acts on the chief cells, and it acts on the ECL cells, which release histamine. And that's going to increase the H+ release even more. Basal secretion is a thing. It follows the circadian rhythm, so it's going to be highest at night. That's kind of where I think you get like some GERD symptoms overnight. That's why, to help things like that, you can have your patient sleep on like a couple of pillows And that's actually exactly why H2 blockers like famotidine are recommended to prevent those reflux spells at night. Secretion of stomach acid has two phases. So cephalad, this is the kind of cool one. It's like you're a young lad and you see, smell, and even taste the food. And then your vagus nerve is like, oh, this food's coming. So it's going to turn on this cephalad phase. It's going to kind of prepare you to secrete all this acid. Then the gastric phase comes in. And this is when the bolus actually hits the stomach. And this is what stimulates the G cells to do their thing. They release gastrin, they turn on all of the acid producers, and then we start breaking down the food, all right? There's also some triggering here with actual distension. So like when the esophagus was distended with a bolus, the stomach is going to feel the stretching because something is now in it. And again, it's going to kick into that gastric phase. Then yeah, D cells and somatostatin, we talked about that. Let's go right into the small intestines. So duodenum and jejunum, the first two parts of the small intestine, they're going to secrete CCK, which is then going to stimulate the pancreatic enzymes and bicarb. So the pancreatic enzymes are lipase for fats, amylase for carbs, and protease. And then again, the bicarb as well, which is going to neutralize acidic environments. So we have the villi, which are the hallmarks of the intestines, and the actual functional epithelial cell there are called enterocytes. The packing of microvilli, which you can see in this picture here, that's known as the brush border. And then we learned about this in anatomy, but the plicae, circularis, Kirk ring, valvulae, canavenentes, which are most visible, I believe, in the jejunum. Yep, yeah, it's right there. That's where most nutrient absorption happens, except for iron. That happens in the duodenum. And then the big other thing we should know is that vitamin B12 and bile salts actually kind of survive all the way into the terminal ileum. So the third and last part of the small intestine is where vitamin B12 and bile salts will be absorbed. All right. Water and lipids are actually passively diffused through the small intestine, but I believe water mostly is reabsorbed in the large intestine. Some blood vessel stuff there. All right, so let's go into the liver. Yeah, I mean, definitely a lot of functions here. Some of the big ones are the synthesis of albumin and bile. We have detox here, like with meds, you know, think about like Tylenol toxicity. You can detox hormones and alcohol. A big one is like energy storage for glycogen. So that's you know, the storage form of glucose, so we can break that down when needed. Also, some metabolism or some energy storage of the fat soluble vitamins and B12, and then we recycle old red blood cells there as well. Large intestine, water absorption, and we make vitamins there, I believe vitamin K. And that's it, going right on to GERD. So there are three mechanisms that result in pathologic GERD. We have the transient relaxation of the lower esophageal sphincter. So it just relaxes randomly and stomach acid comes up into the esophagus, all right? It's kind of part of this mechanism of belching. Sometimes when you burp, you can actually feel a little bit of stomach acid coming up. So that's exactly what's happening here. And it's going to increase with obesity. You can also just get hypotensive, a hypotensive lower esophageal sphincter from like gastric distension. So that's going to kind of open it up a little bit, et cetera, et cetera. You can also just have an anatomic disruption, like with a hernia or like post-op changes. Like if you have like a gastric sleeve, which is a bariatric surgery, then you could have some GERD after that. All right, so definitely probably going to be a question on like what foods to avoid. So you want to avoid peppermint, you want to avoid garlic, onions. The asterisk, I guess tomatoes and citrus fruits, like not as much, but these meds definitely. So the anticholinergics like Benadryl and Bentyl, and we'll learn about some more later as well. And then nitrates and calcium channel blockers. So they're going to relax smooth muscle. So that kind of makes sense where they're going to open up the LES and let some acid through. And then these tricyclic antidepressants for whatever reason, and some opioids as well. And then caffeine is a big one. So a lot of stuff you want to avoid there. All right, so symptoms. So what are you going to look for in a vignette here for GERD. So early satiety, meaning you feel full before you usually are. You're going to feel some bloating and some belching. There's this water brash, which the patient won't tell you, but they'll say they'll have some sour fluid in their mouth. So that's going to be indicative of GERD. Epigastric pain, that's a huge one. That's an anginal equivalent for an MI. So that's definitely a very important symptom you want to rule out, like for an MI, but you're going to get this with GERD, right? That's why it's called heartburn. And it can also radiate to the neck. The globus sensation, which is the feeling of having something stuck in your throat. And then there's some atypical symptoms, which I didn't think were important, but they actually are. So we'll get to that in a second. All right, so GERD can be clinically diagnosed, but we can do an endoscopy as well if we have some alarm symptoms, and there's a lot of them. So if you have unexplained weight loss, kind of an obvious one, right? You want to rule out cancer, so you definitely want to scope there. Any type of dysphagia, odonophagia, which is like very general, but I guess you're not necessarily going to be having trouble swallowing with GERD. If you are, there's probably something structural going on. And if you have painful swallowing, there's probably something else going on as well. So you definitely want to take a look. This is a big one that she asks a lot about. If you have a new onset of indigestion in somebody over 60, you want to take a look. GI bleeding, obviously, any type of anemia, which, hey, could there be bleeding somewhere else? They have no appetite if they are persistently vomiting. If they're not persistently vomiting, you don't have to do a scope, apparently. And if they have cancer in a first-degree relative. Then there's some atypical ones as well you want to look out for. So like a chronic cough. Hoarseness is a big one. Pharyngitis, worsening asthma, bronchitis, palpitations. Sure, okay. And then if you have risk factors for Barrett's, you want to get a scope as well. So she mentioned this. So if you have men over 50, and if you've had GERD for over 5 years, and you're white and you have an elevated BMI, central obesity, etc. So any of those are going to be reasons to scope somebody. And you can use something called an ambulatory pH monitor. So if you need some help to see if somebody has GERD at home, you can use one of those and see what their pH is. Sure, it's called a Bravo test. So remember that. All right, so there's 2 approaches to treatment. This is important. So you can either step up and get your life together first, and if that fails, then go to meds, or you can start with high-dose meds and step down to do other, you should probably still do lifestyle improvements anyway, but the big difference is, are we starting you on high-dose meds and then we're going to step down from that, or are we going to step up to that? So speaking of medications, let's talk about that. So antacids are kind of the boring ones. They take about 30 minutes to 60 minutes to kick in. They're not going to be used for prevention. You're going to take that like after you eat. And you're only going to take this for symptoms less than 1 to 2 times a week. So if you're getting symptoms more than that, then you're going to move on to something else. All right. You've heard of most of these: Tums, Rolaids, Maalox, Mylanta. Okay. Now onto the H2 receptor blockers. So this is your famotidine. Pepcid is probably going to be your most popular, and then cimetidine, Tagamet. So the MOA here, these block the histamine receptor on the parietal cell of the stomach. There are other receptors as well. So this doesn't block like the entire cascade, but it blocks one of them. So it's going to stop the excretion of acid. All right, they take about 2.5 hours to reach peak concentration, but they'll actually last for about 4 to 10 hours. So that's pretty good. So yeah, so Pepcid, really nothing crazy. That's our first line. There's few, if any, drug interactions. Cimetidine or Tagamet does have some severe side effects. So you want to look out for gynecomastia, a loss of libido, and impotence. So I have here, tag your it. You have breast, no sex drive, and impotence. So Tagamet, definitely some serious things to consider there. All right. All right. Now PPIs. And as you go to the right of this chart, these are like more like not necessarily potency, but you're going to get stronger effects from these medications, and you're going to have more side effects. So there's a lot with PPIs here. So these work on the actual like proton pump, which is why they're called proton pump inhibitors. They irreversibly bind there. You want to take these before a meal. All right, they're not meant for a PRN. And I think if you need to take PPIs and H2 receptor blockers, I just think of pH. So you take the PPI first, and then you're generally going to take the famotidine later. Oh, I have it right here. Take PPI in the AM and take the famotidine before bed. So that's hopefully going to prevent those GERD spells at night. They take several days to optimize the acid production. So they're more long-term. H2s like famotidine and antacids are going to do more short-term effects. And there are some side effects. A big one, this is definitely going to be a test question. So omeprazole interacts with clopidogrel, Plavix, which remember is an antiplatelet. But pantoprazole or Protonix is going to be better. So you're going to see that more commonly in inpatient settings, not only because of the Plavix thing, but because it has less of a side effect profile, like overall, all right? The other long-term effect is the chronic suppression of acid to cause infections. Oh yeah, that was that like random CMPP question, whatever. The other big one, it can cause, so PPIs can cause hypomagnesemia, so low magnesium, and anytime you think like magnesium, think cardiac. So that's going to cause a prolonged QT, even torsades, also tremors and weakness. So that's why I have this hypo here, low, hypo, magnesium. And then you're also going to get acute interstitial nephritis and also dementia. I mean, you're not going to get it, but it can cause that. So a lot of potential issues with PPIs. They're the strongest fighters against GERD, so they're going to have some side effects. All right. Here's all the usual suspects here. So omeprazole, pantoprazole, esomeprazole. They all end in prazole, but don't bank on that because fluconazole is an antifungal and aripiprazole, which isn't in this exam, is like an antipsychotic. So don't lean on that suffix, unfortunately, for these. Okay. All right, man, it's taking a lot longer than I thought. So you only medicate when you have more than 2 episodes per week. That was the threshold for when you move away from antacids, okay? So yeah, I mean, that's not super important. You can also manage with an upper endoscopy if you're looking for malignancy. Again, if you have any of those like atypical issues or if you have any of those like red flags, you can do esophageal manometry, which tests the swallowing pressure. These are all your techniques here. So you have 3 surgical ones. You have the Nissen fundoplication. That's where they take the fundus and wrap it around the esophagus. This is where you can get dysphagia, so you can put somebody on a liquid diet, or this gas bloat syndrome. All right, you have the magnetic sphincter augmentation. And what this is going to do is, I believe it like kind of closes the sphincter a bit to prevent the reflux. But you don't want to use this if a patient might need an MRI for something. The Roux-en-Y gastric bypass, this is a bariatric surgery. Patients actually lose a lot of weight after this. So this is only if they are obese and also have GERD. You're not just going to do this for somebody with GERD. You can see here the BMI has to be greater than 40 or 35 with comorbidities. You can do a partial fundoplication with this transoral TIF thing, or you can do stretta, which is radio frequency. You inflate a balloon and you tighten the junction so you don't get as much reflex or reflux. Sure, okay. All right, this is kind of important. There are complications of untreated GERD. We'll just kind of go through some of these. Erosive esophagitis, we're going to use this LA classification system. A is mild, D is severe. C is where you're going to have erosions extending over mucosal folds. Okay. This is usually completely healed when the patient starts PPIs. All right. Peptic stricture is on here. It's a progressive solid food dysphagia that they can get. Diagnosis is going to be an endoscopy to kind of see what's going on. Yeah, dental erosions. This is like acid kind of going all the way up your oropharynx, and it's going to start to erode your teeth. You definitely don't want that. GERD can also induce asthma. All right, Barrett's esophagus is the big one here. So this is where, so again, we mentioned that Z line, which is where the squamous epithelia of the esophagus are going to meet the columnar cells of the stomach. So right at the lower esophageal sphincter there. The issue here is when the acid keeps refluxing, the body is like, okay, I guess this is the stomach now. And it just starts building these columnar cells. You want to know that columnar cells are red and velvety. So picture like a big red velvet column, like at the Met Gala or something, like we've all been to that. So there's a picture there. And then the squamous ones are the pale and glossy ones. All right. So if there's a vignette and you see columnar cells, red and velvety in the esophagus, it's going to be Barrett's. Definitely a lot of vignette stuff with like the average age is 55, more likely in men, white men, obese men. You're going to get Barrett's. All right. Big key here, no symptoms with Barrett's itself, right? It's just the description of a cell change. The symptoms are going to be GERD symptoms, which are causing the Barrett's, okay? Long segment Barrett's is a thing, and that's if something is greater than 3 centimeters, I guess the columnar cells. So just remember that. And erosive esophagitis is an independent risk factor for Barrett's by 5-fold. So again, to actually diagnose it, you need to see the columnar epithelium in the distal esophagus. So look for that Z line that's going to be raised. And then you have to run histology to confirm. So that's how you would actually diagnose. There's a light cancer risk, but there still is a cancer risk. So you do want to screen people, anybody with those atypical symptoms, or men over 50 with GERD, or if you've had GERD over 5 years and you've had some other stuff, hiatal hernia, Caucasian. I think the age is the big one, or anybody like over 5. You really want to take a look and see what's going on. She mentions goblet cells, which I believe are just the same as columnar cells. So they might call those goblet cells as well. 3 kind of ways you can treat this. You can either just treat the underlying cause. You don't want to do a step up. You want to give them the meds to really get that acid production down. You want to do some endoscopic surveillance and take a look, do we have dysplasia? Are the cells changing? Sure. And then you can do radiofrequency ablation. Yeah, I don't know how important that's going to be. But there you go. You want to control symptoms of the GERD so that, we make the problem not as bad. We can't prevent a progression to cancer, but we can help them out. Okay, let's move on. So nausea and vomiting. So we're going to start with the vomiting, which is often preceded by retching. The actual emesis reflex is coordinated by the dorsal vagal complex. We'll talk about that in a second. There are 5 triggers of vomiting, and I have a little mnemonic here to help you remember them. So we're at an amusement park. We're going to take some drugs and toxins and pathogens. That's 1. We're going to get on the roller coaster, and that vest thing is going to come down and lock you in. So this makes you think of the vestibular system, which is like your balance and everything. And then you're on a roller coaster, so you're going to get motion sick. So that's the next one, vestibular and motion sickness. We're moving so fast on this roller coaster, a bird flies into our GI tract and causes a bowel obstruction. And then the roller coaster slows down because we just got hit. So bowel obstruction and gastroparesis. And you think about that, if somebody has a bowel obstruction, food isn't coming out the back end, it's got to find a way out. So that's why you vomit there, because the body needs to get rid of that. Same with gastroparesis. If you're not moving a bolus fast enough, it's going to come out the other end. Then we fly off this roller coaster, hit our head and get a concussion, and then immediate meningitis, which isn't a real thing, but it's increased intracranial pressure. So you think, people vomit after getting a concussion, meningitis, tumor, head bleed, etc. Then you get off this roller coaster and you just anticipate you want to do it all again and you get nauseous. So it's anticipatory nausea. All right, you have this dorsal vagal complex, which is kind of complex, but the important thing here is I think you need to know the area postrema is not protected by the blood-brain barrier, so it's going to respond rapidly to any systemic stimuli. The dopamine receptor antagonists, which we'll talk about soon, are going to act there. They're also going to act on the nucleus of solitary tract, which is kind of like the head honcho here of this whole thing. It's stimulated by the area postrema and a bunch of other things, the splanchnic nerves, vestibular apparatus, cerebral cortex, vagal afferents from the GI tract, because that's actually the only cranial nerve that's going into the abdomen. It's the vagus nerve. So it's bringing information up to the brain from the GI tract, which is kind of cool, I guess. The D2 receptor antagonists are also going to act here. And then the final process of this whole dorsal vagal complex is the dorsal motor nucleus of the vagus nerve. This is what then leads us to vomit. So that's kind of the end result there. All right, so let's talk about some meds. So these are the antiemetics. So the top row here, these are all your dopamine D2 receptor antagonists. Okay. So on the upper left, so this is a matrix of 6. So the first one here is prochlorperazine. This is compazine. All right. It has antihistamine and anticholinergic activity. It's going to be used for motion sickness and nausea. Now, the whole top row here are going to have these adverse effects known as extrapyramidal reactions. This is like seizures, like muscle rigidity, tardive dyskinesia, which is like it's like lip smacking and like facial twitches. So involuntary muscle contractions. So they all can cause these. The big one with compazine, the big contraindication here is elderly patients with dementia. You don't want to give it to them. The other thing with compazine, again, prochlorperazine, is it can cause cardiac effects and hypotension. So just remember that. All right. Phenergan or promethazine can also be used for motion sickness. Again, it's also going to have those adverse effects. But it can also be used for PONV, which is post-operative nausea and vomiting. This is also anticholinergic and also some antihistamine stuff here. The big adverse effect here is going to be fatal respiratory depression in kids less than 2. So I stole this from someone else, but don't give meth to kids. So promethazine, you don't want to give that to kids. So that's how you're going to remember that. All right. The last one here of the D2s is metoclopramide or Reglan. And this is going to be first line for gastroparesis because this is a prokinetic. So it's going to get your bolus moving. So Reglan, it's going to regulate and it's going to move things along, okay? Some more adverse effects here. This one can actually cause prolonged QT intervals, which we don't want. It can also cause galactorrhea. So it's going to cause milk production from prolactin release, okay? So that's our top row. These are all dopamine D2 receptor antagonists. So they all generally have the same mechanism, but just know the big side effects, know what's good for gastroparesis, et cetera. The other 3 antiemetics are these 3. So we have ondansetron, Zofran. This one works on the serotonin receptor. It's a serotonin antagonist, which has to do with the dorsal vagal complex. This is good for chemotherapy, which is why I have Breaking Bad here, chemicals. This is also good for post-op, but this also can prolong the QT interval. So anytime, I've seen this a lot in the ER, when they give Zofran to patients, they always get a baseline EKG to check out their QT. Okay, Benadryl in the middle here. So this is an antihistamine. This is an H1 antagonist. Remember, famotidine Pepcid was an H2 antagonist. Just double check that. Yes. All right, so Benadryl can also be used for motion sickness, can also be used post-operatively. And honestly, nothing else really crazy with Benadryl. Scopolamine, this is what they're going to give you on a cruise ship as a transdermal patch. So this also is used for motion sickness, but it's going to be used as a patch. This is also an anticholinergic. And that's pretty much it. Anticholinergics give you like dry mouth, visual disturbances, drowsiness, but just know that this one is a patch for motion sickness. All right, so nausea, it's going to be triggered by all of the same stuff, basically, that triggers vomiting. However, Vomiting is all about the brainstem, and nausea actually starts up in the cerebral cortex. So, the higher levels of the CNS. And the actual sensation of nausea comes from vasopressin, something called substance P, cortisol, oxytocin, noradrenaline, serotonin. So that's kind of where Zofran comes into play. Okay, if you're feeling nauseous and you don't want to take any medications, then you can do acupuncture, ginger root, sea bands, tart, or cold foods. Very cool. Ginger root, that's probably why they give people ginger ale when they're sick. Okay, let's talk about extreme vomiting. There's two conditions here. There's hyperemesis gravidarum, and there's cannabinoid hyperemesis syndrome. Okay, so gravidarum, as the name suggests, this has to do with pregnancy. All right, big risk factors here are multiple gestation, if you've had it before, if you've had this kind of tumor from a non-viable pregnancy, this hydatidform molar pregnancy. And it's going to present 5 to 6 weeks of gestation, peak at 9, but then it's going to go away by 16 to 20 weeks. You could see dehydration because of all the vomiting, even weight loss. So if you're going to see greater than 5% of the pre-pregnancy body weight, then this is going to point you towards this diagnosis. A big one here that I feel like is going to be on the test is look for ketones on a UA. So if you see that on a vignette, think hyperemesis gravidarum. And if their electrolytes are abnormal because they're losing a lot of fluid, you can admit to inpatient. And the treatment here, this is going to be really important because the patient is pregnant, is just going to be either Benadryl. Actually, they're all pretty fine. It's the whole roster except for scopolamine, which is the patch. So you can literally give them any of the antiemetics: Benadryl, Compazine, Phenergan, Reglan, or ondansetron. But there's a new one. I don't know if this is going to be on there or not, but there's a new med, and this is category A for pregnancy, so that's going to be recommended. It's doxylamine. I'm not going to say all these. I'm usually pretty good with these. Succinate, pyridoxine, hydrochloride, diclegus. There you go. I do have a mnemonic for this. Not going to say this one out loud on the video, but that can help you if needed. And then you have cannabinoid hyperemesis, and just stop smoking pot for this. You can treat with an antiemetic during 24 to 48 hours and give some fluids. That's it. Let's move on to dysphagia 1. Okay, so we have two flavors of dysphagia. There's oropharyngeal and esophageal. This first blue part here is going to be oropharyngeal. So that itself has two parts. There's an oral phase. That's a disorder of poor control. This is where you get like the dribbling from. Food is spilled into the hypopharynx. It can regurgitate into the nasal cavity or the trachea. Yeah, we drool and dribble. Then there's the pharyngeal phase. This is more of that propulsion that I was talking about. So it's either like your tongue can't really move the food back, or there's an obstruction somewhere. And we'll see a cause of that is going to be like CVA, Parkinson's. You just can't control your tongue. You can't move the food. Okay, there's this big chart here. So we'll kind of go through some of this. Some things to ask on an H&P: what medications are they on? Maybe they just have a dry mouth from a med. Remember, we said the anticholinergics can provide dry mouth. They could have Sjogren syndrome, which is going to decrease mucus production, or it could be cancer. There could be something happening that's a little bit more serious going on. All right, so oropharyngeal dysphagia, it's going to happen immediately upon swallowing. That's going to be a big one. You're going to see halitosis here. You're going to see food regurgitation. You're going to see a globus sensation. We'll talk about Zenker's in a second. If you do suspect oropharyngeal dysphagia, your two main diagnostic tests are going to be the barium swallow, which again is just a picture on an X-ray, or a video fluoroscopy, which is actually going to show the entire swallowing process. Those are the two you want to start with, okay? Change in speech is also something you can look for on a vignette. So again, there's those neuromuscular causes of CVA, Parkinson's, even ALS. So those are all things that you want to look out for. And these are some more about the diagnostic testing. Again, start with barium swallow and video fluoroscopy. Fiber optic nasopharyngeal laryngoscopy is a thing. ENTPAs do this, so it could end up on the exam because we do this. You're going through the nose, so you can kind of watch the swallowing process as it happens. Esophageal manometry, this is going to give you info about the tone of the UES and LES. All right, or an upper endoscopy, which actually you need to do under conscious sedation. So it's definitely a little bit more invasive, but it's also going to look at, this is important, below the UES. So you really need to think about, well, where is this issue coming from? Right now, we are up above because we're talking about oropharyngeal. So upper endoscopy is not going to help at all. If there's a neurogenic or myogenic cause, we're going to bring in speech therapy. The patient also might need a PEG tube. If they can't swallow, if they can't get food, into their pharynx, or if they're having tongue issues and they can't eat or drink, then they're probably going to need a gastrostomy tube. So that's what we're talking about next. There are some contraindications. This could totally be a question. Tubes can only be used for 12 to 24 months. This isn't really a contraindication. It's more like just an FYI. You can either do it pre-pyloric or you can do percutaneous. So that's actually what a PEG tube is when they go through the skin. You can do a J tube, go right into the jejunum. There's some other things here as well. So just know about that. There are some other, I didn't put the contraindications here because they weren't really relative. Or they were kind of relative. I think the one I saw on there was with ascites, because you can, there's like a site for infection, but what else would you do? You have to give them food somehow. But anyway, so Zenker's diverticulum, this is a big one here. There's definitely going to be a couple of questions on this. The big thing here is the outpouching, and it has to be above the upper esophageal sphincter. It has to be above that. All right. And where this happens is something called Killian's triangle. So this, which I think looks like a Pope hat, is called the inferior constrictor muscle. And just below that is the cricopharyngeus muscle. So kind of right between there is where this outpouching is going to happen. And you're going to look for this on your vignette, somebody greater than 60, a male, something that's been progressive for months to years. And then halitosis and regurgitation of undigested food. So like food getting stuck and rotting in a garbage disposal. It's just going to come up undigested. It's going to smell awful. You're also going to see a mass in the left neck. So again, something to look for on a vignette for Zenker's. Some complications here, aspiration pneumonia. So if there's food getting lodged in this pouch, it can come loose, it can fall down, it can go into the airway. If your medication of like an NSAID or an aspirin gets stuck in this pouch, it can cause ulcerations or bleeding. And the diagnostic tool here is going to be the barium swallow. If you see a diverticulum, which is the outpouching greater than 2 centimeters, your patient's going to need surgery. Here's my little mnemonic for this. So Zenker, Killian, and Barry, it's for barium swallow, all walk into a bar. They're all men over 60. They go upstairs in the bar, so just above the UES, above the cricopharyngeal muscle. Then they straight up just start regurgitating undigested, foul-smelling steaks onto each other. Then they realize they have mass in the morning, so they all left. So that's that left neck mass. They leave at 2 a.m., so greater than 2 centimeters needs surgery. Okay, we're already on dysphagia part 2, which is kind of a beast, so we'll go through this. So we're done oropharyngeal dysphagia. Now we're moving lower, like below the upper esophageal sphincter. So now we're calling this esophageal dysphagia. All right, now this is where it starts to get fun. Okay, so here's another matrix of 6 things, so we'll just kind of walk right through them. So the first big one here is achalasia. All right, this is the failure of the lower esophageal sphincter to relax. So if the sphincter isn't closing all the way, then you're going to get reflux. Okay, so it's going to be, this is a structural issue. Actually, it's a propulsive issue. It's not a structural issue. Good to know. Right? Yeah, it's totally propulsive. Okay. It takes a while for people to seek care. This is going to have dysphagia for solids and liquids. So that's going to be important. Things to look for on a vignette: difficulty belching, hiccups, and weight loss. So that could point you in the direction of like a malignancy, but it can also just be from achalasia. Another big thing on a vignette is going to be this bird beak on a barium swallow. You can see on the picture there, you know, the food is just getting stuck. And actually, the failure to relax isn't. I just thought about what I said. I guess it's not necessarily a GERD issue. It's not relaxing. It's not letting food. It's not letting food down. So the food is getting stuck in the esophagus. I'm sure it would cause some GERD too, but that's not really relevant in this part. That's what is causing this bird beak. The LES is stuck closed. It's not relaxing. All right, so we can do manometry to show an elevated LES pressure. So it makes sense. A higher pressure means it can't relax, it can't open up. We can do an EGD. You want to do an EGD specifically to look for malignancy, because all of these symptoms of achalasia can mimic a malignancy. All right, it's actually called pseudoachalasia. Some other things can cause that too, but I think the big one is a malignancy. And this can actually be part of a paraneoplastic syndrome. All right, there's a couple of really interesting treatment options here. You can use Botox to relax the sphincter and let the food through. You can dilate it pneumatically. The primary treatment is this thing called POEM, which is a type of myotomy where they cut out a little part of the sphincter so that it can open up. You can use meds here, vasodilators, so calcium channel blockers and nitrates, which are smooth muscle relaxants. Yeah, smooth muscle in the blood vessels. That makes sense. Then there's the most definitive treatment. So don't confuse the primary treatment with the most definitive. This one is the Heller myotomy with a partial fundoplication, which again, a fundoplication is taking the fundus and wrapping it around the esophagus. I think there's some more complications with that. So POEM is a little bit less complicated, I believe, which is why it's primary. Okay, so, oh yeah, look, it says it right here, neuromuscular propulsive causes. All the structural ones are these bottom three. I don't even understand my own graphics. Okay, in the middle here, we have the spastic motor disorders. So there's 3 of them. Again, another mnemonic I'm not sure I'm going to say out loud. But the first one, well, first, so all 3 can present with atypical chest pain. So she has the characteristics here. It's non-exertional, it's prolonged, it interrupts sleep, it's meal-related, it's relieved with antacids. So these are all things that are going to point you in the direction of a non-cardiac cause for this chest pain. Manometry is going to differentiate all 3 of these spastic motor disorders. All right, so the first one is diffuse esophageal spasm. This is your too many, too long. It's also called the corkscrew esophagus or rosary bead. You're going to be having multiple contractions with each swallow. And the whole thing here with these spastic motor disorders are going to be food triggers. And like the best treatment is just stop eating the food triggers. So extreme hot or cold, carbonation, and eating quickly are going to set off this spasm, okay? So again, you can diagnose this with, you can actually do a barium swallow and manometry. You can try calcium channel blockers and nitrates, but again, the best treatment is probably avoiding triggers. All right, so the middle one of these 3 is the nutcracker esophagus. This is also called hypertensive peristalsis. This is your long and strong. This is like the Superman. He's tall and strong. So they're normal contractions, but they're stronger and they're a longer duration. So there's an increased amplitude here. And it's the same triggers as diffuse esophageal spasm. Same diagnosis, same treatment. Last one here is hypertensive LES. The big thing here is that there's no impairment in peristalsis. And it is mid-respiratory. It's defined as a mid-respiratory pressure greater than 45. So again, it's a failure to relax, but there's no impairment in peristalsis. So you could kind of say it's kind of similar to achalasia, but the big difference there is there's no impairment. And all right, so the last one here of the neuromuscular propulsive is scleroderma, which is part of this CREST syndrome. So scleroderma is a cluster of autoimmune issues, and esophageal dysmotility is one of them. So if your vignette has calcinosis cutis, which is white spots under the skin, Raynaud's phenomenon, esophageal dysmotility, which is why this is on this PowerPoint, sclerodactyly, which are thick and tight fingers, or telangiectasia, which are spider veins, your answer is going to be scleroderma, okay? The big presentation here is very severe GERD, and the treatment is going to be, you might have guessed, PPIs or H2 blockers. The treatment here is treating the GERD. Another big thing here, a finding on manometry is going to show hypotensive LES with low amplitude peristaltic contractions. All right, so not hypertensive like over here. This is going to be hypotensive with low contractions. All right, so you have your hypo-hippo with his crest, say less, because that's the lower esophageal sphincter. That's hypotensive. Okay. The structural causes of esophageal dysphagia. These are kind of fun. So esophageal webs, these are non-circumferential mucosal folds, and they're covered with squamous epithelium. I think of this like Spider-Man getting choked. It's in the cervical area, and it's not around the entire neck. It's just anteriorly. That's the big thing here. They're not circumferential. That'll be rings, okay? There's something called bullous, pemphigoid, and pemphigus vulgaris. I don't know. They sound like Spider-Man villains. They have something to do with esophageal webs. The big thing here, though, is Plummer-Vinson syndrome, okay? This is where you get esophageal webs and iron deficiency in mid-aged women. The way you're going to remember that is that if you're a Marvel fan, so Iron Man is gone, iron deficiency. Aunt May, who kind of had a thing with Iron Man, she's pretty sad, right? She's a middle-aged woman. So she's sad, so she rebounds and she dates Vince the plumber, okay? So Aunt May, Spider-Man, webs, so this is esophageal webs. Iron Man is gone, so you have the iron deficiency, and then Vince the plumber. So that's your Plummer-Vinson syndrome, okay? All right, esophageal rings. This is where we have this Schottky ring, which is a B-type ring. It's associated with steakhouse syndrome, which is where food gets lodged in your esophagus. The important thing here is that it's made up of both mucosal and submucosal layers, and it can occur anywhere, not just cervical. And actually, it's going to happen more distal in the gastroesophageal junction. Okay, so these, again, symmetric, concentric rings, they ring around the entire esophagus, both mucosal and submucosal layers. I remember this of when Gollum had Sam in a full chokehold in Lord of the Rings. So rings, esophageal rings, Gollum, just both hands around poor Sam's neck there, and then Outback Steakhouse. Okay, this is commonly going to be a cause of food bolus impaction. And let's talk about treatment for these. So webs and rings, here's an important thing. They present with solid food dysphagia. If it's solid and liquid, it's probably not webs or rings. It's probably going to be achalasia. So if you see that on a vignette, so solid food dysphagia is a big one here. And you want to break the spider webs unless they're massive, and you want to open the rings. So that's going to be the treatment here. So for rings, first-line therapy is dilation. For webs, you're going to break through the spider webs, or if they're massive, then you have to dilate them as well. And they're going to be done by a gastroenterologist. There is peptic strictures here, which I think we talked about a little bit before. Really nothing crazy with those, but they are structural causes. Okay, a few more. So there's two more structural causes, esophagitis and tumors. So esophagitis has 5 subtypes. So let's just go right through them all. So pill-induced medication esophagitis is going to be one. Big thing on a vignette here is a sudden onset of painful swallowing and retrosternal pain, but then obviously a new med and something called poor med hygiene, which I'm not sure is a thing, but I'm pretty sure it is. But what's going to cause this? Well, if you don't do any of these things, if you don't drink water when you take your pills, if you don't sit upright when you take them, if you don't take them before bed, and if you're just not over 70. So those are the ways you can avoid it. Drink water with your pills, sit upright for a while after you take them, don't take them and then go to sleep, and don't be old. Those are the ways you're not going to get this, okay? The big offenders of pill-induced esophagitis, doxycycline, which we're not using technically as an antibiotic, we're using that for acne, to treat acne. So look for that. NSAIDs and aspirin, and then biphosphonates, which are going to be used for osteoporosis. An example of a biphosphonate is alendronate or Fosamax. So if you have a patient who's like postmenopausal, they're over 70, they're taking a bunch of meds before bed without water, it's going to be pill-induced esophagitis. If there's a question about, well, what, your patient has osteoporosis, they need to take a med, you can put them on, I think I missed an N here, but risendronate or Actonel. And I remember that because you act like you got that Riz. So ACT and Riz are going to be how you remember that. Let's see if I spelled that right. It is risendronate. There is no N there. So again, you're going to treat with fixing med hygiene. So drink water, etc. Prevent the triggers. Meds are unclear if they're helpful, but you can try them if you want. Sucralfate is on there with PPIs and H2s. Radiation esophagitis is a thing. It's going to happen actually acutely. I would think it was chronic, but it can actually happen acutely after radiation therapy because radiation is going to thin the mucosa and cause a loss of epithelium. So you can actually put them on pain meds for this. You can do viscous lidocaine to coat the inside of the throat and put them on a bland diet. And then, of course, PPIs and H2 blockers. Okay, infectious esophagitis. We're going to see these in patients with significant immunocompromise, HIV malignancy, organ transplants, all the usual stuff for immunocompromised patients. The two common offenders here are Candida albicans, which is fungal, and herpes simplex virus. You also have cytomegalovirus as well, but I believe that's less common. So let's go through all three of these. Okay, so fungal, you're going to see white plaques on your endoscopy. They're going to be friable and easily crumbled. You're going to treat this with fluconazole. So again, don't get confused with the azole of the PPIs. Fluconazole, think F for fungal. And there are some things you really need to look out for here. So it can actually enhance the effect of warfarin. So it's going to thin the blood. And it can also prolong the QT. And it can cause renal or hepatic impairment. So really be careful there if you're giving fluconazole for fungal infectious esophagitis. The other one is herpes simplex. So you're going to look for lesions on the face and a fever on your vignette. You're also going to see well-circumscribed volcano punched out lesions on an EGD. So big, not red flag, but something to look out for herpes. You're going to treat this with acyclovir or valcyclovir. Valcyclovir, I believe, is just the prodrug. So you can use either of those. Those are antivirals for herpes. Okay, then we have a third offender here of infectious esophagitis, and that's cytomegalovirus esophagitis. I'm going to look out here for our linear longitudinal ulcers or erosions. So, cytomegalovirus mega, so you can think these lesions are mega long. And to confirm this, you have to do a biopsy, and you're going to see these cytomegalic cells. So kind of makes sense. Cytomegalovirus kind of sounds like a supervillain. So you're going to treat this by getting the gang together. So this is ganciclovir IV or PO valganciclovir. There are some side effects to these, and you think of like this supervillain taking over the world. So pan means like the entire world, like Pangea or pandemic. So pancytopenia, which is going to be your entire CBC panel, gets dropped. and then pancreatitis as well. So there you go. We're almost there. Okay. Eosinophilic esophagitis. So this is that kind of allergic reaction that you can get. You're going to see this in children. If you see it in adults too, but I think the vignette will be kids. So you want to look out for if a kid isn't progressing from liquids to solids, or they don't want to eat solids after trying them for the first time, most likely they're allergic to something. They're having this EOE. So that's something you want to look out for. And then there's also some really big things you can look for with an endoscopy, and that's stacked circular rings. So you can think of a kid like stacking little rings on top of each other, linear furrows, and whitish papules. All right. And then these, I guess, strictures, stacked circular rings are kind of the same thing. So that's going to be your eosinophilic esophagitis. To treat this, there's something called the 6-food elimination diet. So you're going to just avoid all the common allergens and then probably reintroduce them and see what was causing it. And then you can also do the inhaled corticosteroids, but I think they swallow these. So that's budesonide and fluticasone, which we learned about in asthma and COPD. And then there's a new medication here. It's called dupilumab or Dupixent. And my little mnemonic here is your structural dysphagia was caused by eosinophils. You had me duped. So do what you want with that. Okay, last thing here is malignant esophageal tumors. This is going to happen in the esophageal cancer belt. So northern Iran, Central Asia, north central China. Adenocarcinoma is going to be the most common offender here, but squamous cell carcinoma can also happen. Look for weight loss. Squamous cell, which we learned about in pulmonary, can secrete parathyroid hormone, which is going to secrete, which is going to pull calcium from the bones, put it into the serum, so it's going to cause hypercalcemia. And diagnostic choice here is going to be, you could do an EGD, but then you can stage the malignancy with an endoscopic ultrasound. I could see that being a question. And these are going to respond better to both neoadjuvant and adjuvant therapy. So neoadjuvant is we do some chemo and radiation before, then we take out the tumor, the mass, and then that's it. And then adjuvant is we take out the tumor or mass and we do some radiation or chemo after. For this, we're going to do all of that. We're going to do before, we're going to take it out, and then we're going to do it after as well. All right, let's do cancer real quick. I'm not going to do pulmonary circulatory, but let's do neoplastic. Okay. How long is this? Okay, let's dive right into it. So non-small cell lung cancer, there are 3 types. Now, this is the most common one when we're combining this to all other lung cancers. 85% are going to be non-small cell lung cancer, okay? 90% are from smoking. You can also get it from radon or asbestos, okay? Adenocarcinoma is, we were just talking about that, #1 type of non-small cell lung cancer. It arises from the bronchial mucosal glands, and it usually develops peripherally. So think adenocarcinoma around the outside, but knowing that the glands are involved here, that's 100% going to be a question. Squamous cell carcinoma is the second. I think this is like the 3 C's, but it's centrally located, so it's not around the outside. It has cavitary lesions, because this kind of looks like sarcoidosis or TB or an abscess or fungal pneumonia. But I try to think like squamous square. It's square center in the chest. It's centrally located in the cavity, cavitary lesions. The other big thing you're going to look for are keratin pearls and hypercalcemia. I remember the keratin pearls because squamous, like a mouse pearl necklace, like Mickey Mouse or something. I don't know. It works for me. And then the third one is large cell carcinoma. You're going to see a large mass on chest x-ray or atypical large cell sheets. You're not going to see the gland formation. You're not going to see the keratin pearls. So large cell carcinoma, which makes sense because it's under non-small cell lung cancer. Okay. The local spread of both non-small cell and small cell can be with vein. So we'll go through that in a second. For non-small cell, most are going to be asymptomatic until the cancer is well advanced. If there's a primary tumor, the presenting symptom, the number one presenting symptom is going to be a cough. They could also have a pleural effusion. They can also have local wheezing. If it metastasizes, you can get weight loss, cachexia, jaundice, scleral icterus, papilledema, morning headaches from increased intracranial pressure, which means it spread to the brain. You can have acute spinal cord compressions. So if they present with weakness, paralysis, paresthesia, incontinence, you have to do an emergent MRI, okay? Sputum cytology is useful for non-small cell. Remember that. Sputum cytology is useful for non-small cell lung cancer. It is not useful for small cell lung cancer, and let's talk about that right now. So this is oat cell cancer, or it's the AKA name. You can get this from uranium mining, but also from radon. This is rapid growth and an early spread to distant sites. So this has a dismal prognosis. That's why I put it on in red on the right here. So just think small cell lung cancer, it's harder to find, so it's going to spread all over the place, so it's going to be worse. It is going to go to around the bronchioles and in the submucosa. Again, so we can get some wheezing and hemoptysis this time. If there's a primary tumor, it can obstruct the major airways. Something that's unique to small cell is going to be, versus non-small cell, is going to be Beck's triad for pericardial tamponade. So don't forget, jugular vein distension, hypotension, and absent or muffled heart sounds. You can also see a water bottle heart on a chest x-ray. Can also get metastasis to the spinal cord. He also mentioned specifically for this one, I don't know if you can get it with the other one, is supraclavicular adenopathy. All right, there's more physical exam signs for SCLC, and this is going to be one of them. Sputum cytology, not good. So it is not good for small cell lung cancer. All right, so just think spitting, sputum, if it's small, you're not going to be able to see anything, right? It has to be a non-small cell lung cancer to be able to see something on sputum. Don't know if that's the case, but it makes sense. The other thing here is so the TNM system, which is like tumor size, N is lymph node, and M is, isn't it just metastasis? Double check that real quick. Yes. So that can be used for both, but small cell lung cancer also uses this Veterans Administration Lung Study Group. It's actually the most commonly used staging system here. For the small cell lung cancer. Treatment pretty much for both of these is kind of the same: surgery, chemo, radiation. If they do have mets to the spinal cord or brain, you can just give them dexamethasone. Who knew? All right, so that could be a big one. You also have this tumor lysis syndrome, which I believe when we're blasting this tumor, we're breaking it apart and it's just going haywire, and that can actually cause hyperkalemia and even sudden death. So we don't want too much potassium. That could definitely stop our heart. Okay, real quick, the local spread of tumors, which can happen with both of these. There's the vein mnemonic. So V is superior vena cava syndrome. This is where you get that facial fullness, upper extremity edema. Okay, you can get airway tracheal compression, so stridor dyspnea. Nerves, a PANCE tumor at the lung apex. That's Horner syndrome. That's going to be a question tomorrow. A PANCE tumor at the apex. That's Horner syndrome. If you have hoarseness, it's going to be from the recurrent laryngeal. If you have diaphragmatic paralysis, it's going to be a phrenic nerve issue. And then you can have UE neuropathy from the brachial plexus. And then esophagus, dysphagia, which we kind of talked about that just a bit. All right, let's talk about paraneoplastic syndromes. There are 6 of them. From what I understand, all 6 were mentioned for non-small cell lung cancer. Only 3 were mentioned for small cell lung cancer: the syndrome of inappropriate ADH production, Cushing's, and Eaton-Lambert. And then only one was mentioned for carcinoid, which again was syndrome of inappropriate ADH. So let's just kind of go through them all. So hypercalcemia, this is where you're going to have like a parathyroid hormone, like mimicking tumor, pushing out all this PTH. Again, it's pulling calcium from the bones. It's putting it into the serum. So you're going to get hypercalcemia, okay? Because of this, you're going to get weakness, lethargy. It's generally a rapid progression. You're going to have renal failure here as well. And then I believe pathologic fractures, because if you're pulling calcium out of the bones, it's going to weaken the bones. So that makes sense. Okay, syndrome of inappropriate antidiuretic hormone secretion. Antidiuretic hormone prevents diuresis, so it keeps fluid in our system. When you drink alcohol, it inhibits ADH. That's what makes you pee. That's what breaking the seal is, which is a myth. But that's why you urinate so much when you drink alcohol. You're inhibiting antidiuretic hormone. You're releasing a dam. Okay. So if we're creating too much ADH, we are putting up more walls to this dam. We are retaining all of this fluid. So our blood is going to get diluted. So now there's a higher concentration of salt outside of the blood vessels. So the water is going to follow the salt, go out of the blood into the cells. The cells are going to swell, and the brain isn't going to like that. So we're going to have neurosymptoms. We're going to have seizures and coma. Okay. And we're going to have overall hyponatremia in our serum, in our blood. Okay. So just remember, the brain does not like any small changes to sodium, and this is going to be quite a big change here. Okay. And again, I don't even know if I explained, these are paraneoplastic syndromes. So these are kind of syndromes, paraneoplastic, that happen around having cancer. They're triggered by this altered immune system response to the neoplasm. And they can actually be the first presentation of a patient with cancer. So if we pick these up early, we could potentially give them a better prognosis. Okay, Cushing syndrome. This is another paraneoplastic. This is from another pituitary hormone. I don't know if I mentioned ADH is from the pituitary. Adrenocorticotropic hormone, I believe, is ACTH. Here, we're going to have moon phases. We're going to have the buffalo hump. We're going to have hypernatremia. So we're going to have high sodium this time, and we're going to have a low potassium. Okay. Trousseau syndrome. I think about this like you've treated your body like crap and you have lung cancer, unfortunately. Your body has had enough, and it's writing out in your veins with blood clots in your legs the word truce, like, hey, enough of this already. So that's Trousseau syndrome. It's a cancer-associated coagulopathy. It has to do with migratory superficial thrombophlebitis. Okay, you're going to get these lesions in the trunk or extremities. Another one, we have hypertrophic osteoarthropathy. So this is going to be, there's a triad here. It's digital clubbing, periostitis, and joint pain. And my mnemonic for this is you're in the club, so digital clubbing. You're in this digital club. You're drinking Dom Perignon. I don't know if I'm saying that right. I've clearly never had that before. So that's periostitis. And you're smoking something. So you're having joint pain from arthralgias. So that is your triad for hypertrophic osteoarthropathy. Okay. The last of the paraneoplastics here are Eaton-Lambert myasthenic syndrome. You're going to remember this because when you're eating in a chair, you just don't want to get up. So Eaton-Lambert, it's going to have to do with difficulty rising from chairs, walking, and climbing stairs. All right. The path behind this is impaired acetylcholine release in the neuromuscular junction. All right. And some other stuff here. Again, the TNM system for staging can be used for both, but it's better for non-small cell. If they have a T4, that's a full-on invasion. It goes from 1 to 4. 3 on the N, which is nodes, is going to be contralateral involvement of lymph nodes. So lymph nodes on different sides of the body, which is going to be a poor prognosis. And then metastases is just 0 or 1. Are there Mets or are there not? We already talked about adjuvant and neoadjuvant therapies. Neo is where Neo from the Matrix comes in before the surgery, hits you with some radiation and chemo, and then we go ahead and take the tumor out because, you know, we want to shrink it first to make it a little bit more manageable. If a patient has an FEV1, the forced expiratory volume in 1 second, less than 1 liter, they're not going to be a surgical candidate because the surgery for this is going to be, we're taking out parts of the lung. We can do a resection and take out some, or we can take out the whole thing. We can do a lobectomy. I don't know if this will be on it, but cisplatin was a chemotherapy agent mentioned for non-small cell lung cancer. Make sure your patient has their immunizations. And we're almost there. Oh my gosh. Okay. So carcinoid tumors, these are a thing. These are neuroendocrine tumors, and they come from the GI tract, okay? They are highly vascular tumors. So that's probably a big one for a vignette. They're highly vascular, and they produce a variety of biologically active peptides and hormones. We can also get syndrome of inappropriate ADH production and Cushing's here as well. So again, the ones that involved hormones with the paraneoplastic. We have a new thing here. This is serotonin syndrome, and there's a triad. So serotonin, is out of her mind, altered mental status, buys a hard muscle car, muscle rigidity, and then drives that automobile into a stable. So autonomic instability, auto-instable. That is the triad for serotonin syndrome. It can just be a secondary drug interaction with SSRIs, but this is kind of like mimicking that because the tumor is producing serotonin. So there you go. So the Cushing's-like stuff is back. He mentioned hirsutism here as well, which is like excess facial hair. I don't know if you get that with Cushing's as well. I actually think you do. It just wasn't mentioned on the other slide. So it's all the same stuff here. It's buffalo hump, it's moon faces, etc. Oh, the one thing I didn't mention, if you do suspect the syndrome of inappropriate ADH, you give them 3%. You give them hypertonic saline, because remember, their serum sodium is down. So we want to give them more salt, bring that fluid out of the cells so the cells can go back to normal size, okay? Ectopic insulin production is a thing. Patients can present with recurrent hypoglycemia and high insulin levels. So again, this carcinoid syndrome is just mimicking all of these hormones. Carcinoid tumor, you might have a hilar mass on a chest x-ray. You might see nodule calcification. So if you see calcifications, it's most likely going to be carcinoid. Highly vascular, like we mentioned before, is another giveaway. You're going to do CT with contrast, and it should light up like a Christmas tree. The only successful therapy here is surgical resection. So no chemotherapy, no radiation here. And despite the scariness of all this, it has a better prognosis than primary lung cancer. So if you find this early enough and you take it out, then you should be okay. Okay, the last thing, pulmonary nodules. They have to be less than 3 centimeters in diameter. If it's greater than 3, then we treat it as a malignancy, all right? It has to be well marginated, well rounded, and completely surrounded by lung parenchyma. So no hilum, no mediastinum. It's got to kind of be right in the middle, just surrounded by lung cells. We're not going to see anything else. We're not going to see adenopathy, atelectasis, or pleural effusion. The nodules can be malign or can be benign or malignant. We can get granulomas here. You can get this in sarcoidosis. There's something called Wegener's and granulomatosis and lipoid pneumonia. Just remember that all has to do with pulmonary nodules. The most malignant are going to be adenocarcinomas. These are going to be calcified, but they're usually, most malignant nodules are adenocarcinomas, period. Calcified lesions are usually benign. So that's actually not a bad thing when it's calcified, which kind of makes sense if a carcinoid tumor has nodule calcification and it has a better prognosis. You want to look at the doubling time. If they double in size less than a month, it's an infection. If it's greater than 18 months, it's benign, okay? CT can pick up as small as 3 millimeters. The nodules here, if it's greater than 2 centimeters in diameter, they're going to be high risk. Basically, if it's smaller than that, it's low risk. If they're a smoker and have cancer history and they're over 60, they're going to be at a high risk for pulmonary nodules. All right, that's it. Good luck.